Things have changed with robotic surgery and the loss of our ability to put our hands into the chest, the loss of tactile sensation, the lack of finger palpation. It's concerning that we may be leaving cancers behind that we can't feel anymore. So I always felt there was a way we could do surgery better. And we would do perfect operations, and then sadly, 6 months later, a year later, the patient would come back and have a recurrence, and the tumor would be back. And that's the impetus for intraoperative molecular imaging. The concept of intraoperative molecular imaging is that we inject patients before surgery with a contrast agent that can localize the tumor better. And on occasion, we can actually find cancers that were missed on the CAT scan or the PET scan. Lung cancer expresses folate receptor almost 10,000 times more than a normal lung cell. And by targeting the cancer cell with this fluorescent agent, we could make that tumor cell fluoresce. It's a tracer that targets the folate receptor on lung cancer to see deeper into the lung. And by allowing us to see deeper into the lung, we had the ability to find more cancers. As I really do think we have the opportunity to do surgery better. And now that we have this technology and it's gotten FDA approval, it's exciting to know that this may someday be the standard of care for patients with lung cancer. Ultimately, it's nice to walk away from the operation feeling you've done a complete operation and that you have some confidence that you used every tool available at the time. Intraoperative molecular imaging is the beautiful part is you can inject it systemically. You don't need to know before the case where the nodule is. It just naturally goes to the cancer. It makes it fluoresce. It doesn't have any added procedures. Margins can be extremely hard, especially for ground glass opacities and small lesions where it's hard to feel them. This technology is particularly good for ground glass opacities, and many patients do develop the syndrome where they develop ground glass opacities throughout their lung. So there's a tremendous amount of benefit of being able to locate them first and avoiding an operation maybe 2 years down the road when that ground glass opacity grows bigger. I think that this is the time that's very important for intraoperative molecular imaging because we are picking up nodules earlier in their course when they're smaller. So I think the phase 3 trial was extremely informative. It was an important study and actually a groundbreaking study because it was the first time that intraoperative molecular imaging had undergone a multi-institutional randomized study. The results were extraordinarily interesting. In over 50% of patients, we had some clinically significant event, a situation where we found the positive margin or found the second cancer, or we were limited by our ability to localize a tumor. It's very exciting to be at the forefront of this, and I suspect that over the next decade, we're really going to see this technology evolve with more applications, deeper penetration, and it's an exciting time to be part of this adventure.